But I would say echocardiogram, pulmonary function testing, and a VQ scan are the most helpful three things to help sort of sort out what the etiology of your undifferentiated shortness of breath or swelling or whatever else you have. And then if the suspicion is high for pulmonary hypertension based on those things, there's publications that when patients get right heart catheterization outside of a PH center of excellence, about a third of the time, their diagnosis ends up getting changed on repeat right heart catheterization. Testing of primary family members, especially children of patients who have pulmonary arterial hypertension and BMPR2 positivity, can help inform family screening, help inform prognosis.
Hello, and welcome to part 2 of this deep dive series with me, your host, Dr. Saranya Ravindran. Let's dive in. So tell me about the current diagnostic workflow from your initial suspicion to then confirmation of PAH.
So one thing that the World Symposium and the European Respiratory Society and European Society of Cardiology have done a great job at is publishing diagnostic workflows. Now, if you were to read the Seventh World Symposium guidelines published in 2024 or the 2022 ERS ESC guidelines, what you would notice is that they all have this table that shows a diagnostic workflow for the evaluation of pulmonary arterial hypertension. But in reality, I actually think it's a great workflow for the evaluation in a patient who has shortness of breath or symptoms consistent with right heart failure, but who hasn't developed, where that hasn't come onto the differential yet. And that starts really with a good history and a good physical. I think all providers would assume that that's something good, but sometimes asking the questions of how long has this been going on? What are your symptoms? What was the progression? How over what time? This should be followed by an echocardiogram and pulmonary function testing. Now, in PAH, pulmonary function tests should be normal with one exception, and characteristically, patients with PAH have normal flow patterns, but a low diffusion capacity. And just for those of you that don't think about pulmonary function tests that often, the diffusion capacity is otherwise known as the DLCO. And that's the ability of oxygen to move across that membrane from the alveoli into the bloodstream. And then finally, a ventilation perfusion scan to rule out thromboembolic disease. In chronic thromboembolic disease, getting a CT scan or a PE protocol CT scan can be misleading. And the reason is that patients with chronic thromboembolic disease do not look on PE protocol CT scan similar to patients who have an acute PE. So we use a VQ scan because it's much more sensitive. There are some other tests, but I would say echocardiogram, pulmonary function testing, and a VQ scan are the most helpful three things to help sort of sort out what the etiology of your undifferentiated shortness of breath or swelling or whatever else you have. And then if the suspicion is high for pulmonary hypertension based on those things, you would go for right heart catheterization, which confirms the hemodynamic parameters that classify a patient with pulmonary arterial hypertension from group 1 diseases.
And how about something like NT-proBNP?
Yeah, these are, the NT-proBNP and things like echo are wonderful for screening and also after diagnosis for a concomitant risk stratification. We're trying to minimize people's long-term risk of morbidity and mortality. And we use it for that. But prior to the diagnosis, they're great for screening. What they're not good at is diagnosis. And it's simply just because they're not precise enough, either hemodynamically or correlating with disease severity to be used as a diagnostic pathway. Echo can estimate pulmonary artery pressures to some degree, but it's less useful for clarifying what the etiology of the disease is. Is this group 2 disease? Is this group 1 disease? And what I can tell you is there's tons of patients who have what looks like a beautiful left ventricle and left atrium that in fact have group 2 pulmonary hypertension due to left heart disease from heart failure with preserved ejection fraction. The other thing that's notable is that echocardiogram can over or underestimate the severity of pulmonary hypertension. And this is important because when we put patients on therapy, we often think about this from a severity standpoint. There's been multiple studies actually that have shown that echo and right heart cath do not align well hemodynamically in about a third of patient cases, even when the tests are done on the same day. Right heart catheterization, for that reason, remains the gold standard for diagnosis.
And, in that vein, on the right heart catheterization, can you walk us through some of those values when you're interpreting that study?
Absolutely. So these values actually have changed a little bit over the last 5 years or 5 to 7 years, depending on what guideline you're looking at. But to diagnose group 1 pulmonary arterial hypertension, you need a mean PA pressure greater than 20 millimeters of mercury. For those who studied prior to 2018, you may remember this was 25. It's the threshold has been lowered to 20 millimeters of mercury. You need a pulmonary vascular resistance greater than 2 Wood units. Again, for those who studied a while back, this used to be 3. It's subsequently been lowered to 2 for good reasons. And then a pulmonary capillary wedge pressure or left atrial pressure, or LVEDP, less than 15 millimeters of mercury. And the important thing for diagnosing group 1 pulmonary hypertension really is to get an accurate pulmonary capillary wedge pressure, because this helps to rule out left heart disease, and to get an accurate pulmonary vascular resistance, or to be able to calculate that accurately, because that rules in group 1 pulmonary hypertension.
So when you're referring patients for RHC, who is it that's doing that procedure?
In our hospital, we have our pulmonary hypertension program is a mixed. We have some wonderful cardiologists. We have some wonderful pulmonologists. Both the cardiologists and the pulmonologists do right heart catheterization procedures. We have the luxury of being able to do quite a bit of research in that. And so we have multiple units in a pretty high volume. I think I would say many places have cardiology assistants to help them out with this. What I would say to your audience is, it doesn't matter whether you're a pulmonologist or a cardiologist or whoever. What matters in getting an accurate diagnosis of pulmonary hypertension is to have the patient referred to a person who knows pulmonary hypertension and the nuances of pH and what to look for. Because there's a lot of traps, probably beyond the scope of this podcast, that can get patients misdiagnosed. And interestingly, there's publications that when patients get right heart catheterization outside of a pH center of excellence, about a third of the time, their diagnosis ends up getting changed on repeat right heart catheterization. So if you're a patient and you have a 1/3 chance of getting referred to a center and your diagnosis being completely changed, in my opinion, that's an unacceptably high rate of changing diagnoses. And so the guidelines uniformly recommend that if you're not a pH center of excellence, or there's limitations in the proficiency of somebody, or experience of somebody doing right heart catheterization for the purpose of pulmonary hypertension, the goal is to refer that patient to to a pulmonary hypertension center of excellence where they can get great care.
And tell us about vasoreactivity testing. What kind of role does that play, and who might benefit from calcium channel blockers?
Great question. So I'm going to give you my personal opinion. This is not guideline driven in my opinion, but I think vasoreactivity testing is not helpful. And let me defend myself a little bit here. So early on in the literature, studies reported that somewhere between 5 and 10% of patients were what we call vasoreactive. And essentially what that meant was these patients responded to therapies like epoprostenol or inhaled nitric oxide, and they represented in longitudinal studies this special phenotype of pulmonary arterial hypertension that would benefit from high-dose calcium channel blockers. Now, this is helpful from an economic standpoint, but the other thing that these patients were shown to have is a wonderful long-term survival that approximated 95 to 100%, which was far greater than the standard patient with pulmonary arterial hypertension. In reality, and I think that almost any large PH center of excellence would report this, the prevalence is far lower than 5 to 10% of patients. And so while we still do vasoreactivity testing and probably should still do vasoreactivity testing in patients who are being diagnosed with pulmonary arterial hypertension, we need to recognize that finding these patients is a little like finding hen's teeth. You're not going to find this in 10% of your patients. There are very strict guidelines in the literature for how one would diagnose vasoreactivity tested. But I'm not sure that it's an essential component to sort of the broad treatment of pulmonary hypertension, given its rarity.
And you mentioned earlier on about a genetic predisposition in some of these patients with PAH. When would you select them for genetic testing? When is that appropriate? And who are the patients that benefit most from that?
This is a great question, partly because what I can tell you is that the Europeans do a much better job than the Americans in this. And that was highlighted actually in the 6th World Symposium on Pulmonary Hypertension. It's sort of the lackluster approach that most American physicians have taken to genetic testing. And European communities have really led the way on the benefits of genetic testing. So in patients who have otherwise idiopathic cases of pulmonary arterial hypertension, or there's some family history of other patients or other relatives to the patient, it's appropriate to get genetic testing. The guidelines actually recommend that anybody with pulmonary arterial hypertension receive genetic testing and potentially counseling if needed. There's a couple of genetic variants that can lead to PAH. Most common one of the mutations, and probably the one that people might see on a board exam, would be something called the BMPR2 mutation. BMPR2 is an autosomal positive or autosomal dominant mutation, but it carries a very low penetrance. So even though it's autosomal dominant, there's only about a 20% penetrance. That being said, testing of primary family members, especially children of patients who have pulmonary arterial hypertension and BMPR2 positivity, can help inform family screening, help inform prognosis, and then also potentially future gene-targeted therapies as we move forward with, increased alacrity in our ability to treat these things in a targeted fashion.
And do you see a future for biomarkers or any advances in imaging or machine learning and improving early diagnosis of PAH?
Yeah, absolutely. So probably the most widely used biomarker that we have right now is obviously NT-proBNP or BNP. But there are tons of emerging omics, quote unquote, based markers that could help with early detection and risk stratification. None of those have been commercialized to my knowledge at this point, and none are guideline based. But things like cardiac MRI, which had been around for a while, but really have been fairly limited because of patient tolerability of being in an MRI or gating. These things, as we make advances in how we do MRI and the capabilities of MRI, are certainly promising from an imaging standpoint. And then finally, machine learning, I think, is going to take us to a new place. There's a ton of research being done using machine learning models and exploring those to look at massive databases of patients to help flag subtle patterns based on things like omics markers or EKG or pulmonary CT patterns, or even non-invasive things like microcirculatory profiles on patients. And the benefit of all these things is that we are going to move increasingly from a profile where we rely on the patient's symptoms to change management to a profile where we can detect changes in their disease long before symptoms emerge.
Yeah, which is very exciting, I suppose.
Oh, for sure.
Yeah,
it's a
and
fun time to be a part of this disease.
thank you for listening to part 2 of our conversation. Make sure you tune in for the next installment in our deep dive series.